Welcome to SLP Nerdcast, your favorite professional resource for evidence-based practice in speech-language pathology. I'm Kate Grandbois.
And I'm Amy Wonka. We are both speech-language pathologists working in the field and co-founders of SLP Nerdcast.
Each episode of this podcast is a course offered for ASHA CEUs. Our podcast audio courses are here to help you level up your knowledge and earn those professional development hours that you need. This course, plus the corresponding short post-test, is equal to 1 certificate of attendance. To earn CEUs today and take the post-test after this session, follow the link provided in the show notes or head to slpnerdcast.com.
Before we get started, one quick disclaimer. Our courses are not meant to replace clinical advice. We do not endorse products, procedures, or other services mentioned by our guests unless otherwise specified.
We hope you enjoy the course.
Are you an SLP or related professional? The SLP Nerdcast Unlimited subscription gives members access to over 100 courses offered for ASHA CEUs and certificates of attendance. With SLP Nerdcast membership, you can earn unlimited CEUs all year at any time. SLP Nerdcast courses are unique, evidence-based, with a focus on information that is useful. When you join SLP Nerdcast as a member, you'll have access to the best online platform for continuing education in speech and language pathology. Join as a member today and save 10% using code NERDCASTER10. A link for membership is in the show notes.
Welcome to SLP Nerdcast. I'm really excited for today's episode. I am here without our regular co-host today, Amy, but I am not alone. I am very excited to welcome our content expert and guest, Dr. Reva Bearwall. Welcome, Reva.
Thank you.
So one of the things that I love about being the host of this show is I get to talk to so many different kinds of people from so many different disciplines, and you are going to bring so much great, interesting, unique perspective to this conversation today, just given the nature of your background. I would love to start off by having you tell our audience a little bit about yourself and just what perspectives are you bringing to the table for today's conversation?
Yeah. Where do I start? I am a prosthodontist. I think that's the hardest, the hardest place to start, because most people don't know what that is.
Including me, but we'll get there.
Yeah. Yeah, it is essentially an oral reconstruction specialist. So I am a dentist that went to postdoctoral residency program to become a prosthodontist. And what that really means is that I understand chewing or mastication really well. And I spent 3 decades in research, clinical practice, teaching at Oregon Health and Science University, essentially prosthodontics. I also am a board, I do sleep disordered breathing and, worked alongside with physicians. So prosthodontics is kind of this, you can do anything you want with prosthodontics, really. It's where you want to take it. And it's just a really interesting term because it just isn't catchy like orthodontics and oral surgery. I mean, everyone knows what that is. In fact, our dean stood on the street and he asked people on the street, like, do you recognize this term? And most people recognize proctologist way more than prosthodontist. So that just gives you the perspective.
I believe it. I mean, I have been in the field for over, 15 to 20 years almost. And I have never heard this term. And I am dying to know how you found this niche.
Yes.
What led you to study this?
Well, it's interesting because we interconnect with head and neck cancer patients because, of course, there's a lot of impacts to the oral health with head and neck cancer, surgical, post-radiation, et cetera. So it was really my patients that I was treating that had dysphagia. And I was working with them and learning about, as I'm reconstructing the mouth so they can chew better, having dysphagia means that they're on a texture modified diet sometimes. And so that really created this disconnect in knowledge, between what, and it's interesting because in Japan, dentists learn about dysphagia, but in the US and
Interesting.
Canada, in North America, they don't. And
Interesting.
so it was really this strong disconnect as to like, what am I doing? What am I doing for this patient really? Is it purely aesthetics if they're not using their teeth for function? And in fact, it was one patient named Jen who really scintillated the importance of chewing for me, and the deprivation of not having that sensory stimulation and the dignity of just eating, biting. And she said, "You can." I was just drinking my food at one point, and all I wanted was something to bite. So that kind of almost primal need was gone. And understanding that connection to the emotional centers and, that engagement with food and everything, it really made it clear like what I'm doing or what I'm not doing has huge impacts to this person's quality of life, and it could be a lifetime. And so I really then decided to study dysphagia science and food science and match it, connect the dots between mastication and the pharyngeal phase of the swallow and food and everything together. Because to be honest, it's hilarious that dentistry and medicine are separate, and that we have our system was created that way to compartmentalize the mouth away from the body. Like that just makes no sense.
It doesn't make any sense, and I have never thought of it that way before. And I now I can't unsee it. That makes absolutely no sense.
Yeah, it's crazy. Like we're learning about the gut biome and how that influences the brain, right?
Right.
And essentially influences everything. And so we are learning that no, we are not siloed. We are extremely complex and everything connects. And so one day our insurance plans will take that into account too. So yeah, so that's kind of the backbone.
I have already so many more questions and so many more comments, but I'm going to rein them in so that we can stay focused and stay on task. Before we get into more conversation, I do need to read aloud our learning objectives. So I'm going to do that quickly for our audience, and then we'll get right back to it. After completing this episode, participants will be able to self-report knowledge gains related to the neurophysiological role of chewing in activating cortical and brainstem networks involved in swallowing. Participants will also be able to report knowledge gains related to the clinical implications of disrupted oral phase sensory input due to texture modified diets, as well as knowledge gains related to the potential benefits of functional food textures in supporting oral motor engagement and swallow efficiency in individuals with dysphagia. For anyone who is listening who would like to learn more about financial and non-financial disclosures for both of us today, all of that information will be listed on our website on the episode page. You can find a link to that information in the show notes. And if you are listening to this course to earn ASHA CEUs or certificates of completion, the link to the post test is also in the show notes. That is all of the boring stuff. We are ready to get right into it. So right out of the gate, I have so many thoughts and comments just about being siloed and speech pathologists not frequently working with dentists, much less prosthodontists. And I'm now concerned I'm not even pronouncing that name, your professional title correctly. Could you start off by just telling us a little bit more about what it is you do and how that is related to our role? So, right. So our Venn diagram of scope of practice and scope of competence, where is it that we overlap?
Yeah, I think so if we look at how it's described in your literature, it's called the oral phase, right? And so what's interesting is the terminology that you guys use is not terminology that we use, but it's descriptive of the same thing, right? Like bolus containment, bolus propulsion, lip seal, tongue pressure, cheek and jaw movement, and things like that, we are looking at it very differently. So it's interesting how terminology kind of like can kind of like veer us in different directions, if you will. So I think that, what I hope to kind of share with you today is how the way that prosthodontists think and the way that SLPs are trained are actually more similar than different. And that when we kind of take a view that from our training, it's kind of a very traditional view, there are so many pieces of the puzzle that are missing. And so, what I'm trying to do here is modernize the view of what the oral phase is by bringing the knowledge from prosthodontics and dentistry, to be honest, into the conversation. Because I actually think at the end of the day, it's going to help better understand the system involved in the swallow. And the system isn't just the oral phase of the swallow, it's the entire swallow pattern. So I think that by learning from SLPs, which I have done over the past decade, and you know, bringing this knowledge, I think we're going to see that the system is actually more complex and beautiful than we ever thought.
Well, again, I have so many more questions. So what are we missing? I mean, that's the big question then there, isn't it? I mean, it sounds
Yeah.
like we're missing quite a lot, vocabulary, terminology, right? And that's so classic from siloed professions. We make up words to serve our colleagues and not anyone else. So aside from those vocabulary barriers, what what are what are the other things from your field that shape our knowledge in terms of the pre-oral and oral phase?
Well, that's actually like a huge conversation, because we could get into the interesting thing, Kate, is that, I was just recently at a conference and they were talking about respiration and how the swallow is timed with respiration. And, this is like a big concept. And I was just sitting there in the audience going, well, have you ever tried to chew and swallow at the exact same time? No, your teeth come together when you propulse your bolus towards your pharyngeal swallow, right? Like your teeth come together every time you swallow.
Oh my gosh, they
So
do. I'm
there,
sitting here.
there is
I'm
a
sitting here
rhythmic,
swallowing.
yeah, try it. There is a rhythmic pattern to chewing, press, swallow. And our brain does this over and over and over again. So, so I bring that up because what do we do as dentists, or what do patients do, as opposed to respiration, which of course we can talk about apnea, sleep apnea all day, or different kind of sleep disrupted breathing. But my purpose is to say, gee, dentists extract teeth. What does that do? Place dentures, place implants. The saliva actually changes too in the mouth, which affects everything. So we are iatrogenically sometimes modifying uh, essentially the environment that is directly responsible for one aspect of how we time in the mouth to the swallow. So, so take for instance, like try to keep your teeth apart and swallow.
I
How
can't. I
hard, how
can't. That was
hard is
the
that?
weirdest experience.
Right? It is,
Everybody listening just tried to do it. If you didn't try to do it, you have to try and do it right now. I don't think that was that was a really weird sensation.
yeah. Keep your lips together, keep your teeth apart, and swallow. Was it harder to swallow?
Yes, I couldn't initiate the swallow.
Exactly. So, so just imagine someone with no teeth,
Oh my goodness.
right? How many patients of an SLP just decide they're not going to wear their dentures, right? So their dentures don't fit. And it's not the fault of the patient. It could be very well many other factors that we don't have time to talk about today. But the point of the matter is, this is a change to that oral environment that directly impacts the swallow. What if you took three tongue blades or two tongue blades, and you put them in your mouth. You broke them in half so they fit within your lip seal, and then you tried to swallow. So what if your teeth are too big, meaning those dentures barely fit in your mouth? They're too big. How do you swallow? And you can't.
Oh my
So
goodness
like
gracious.
people don't know that, right? Like the oral phase is critically important to the swallow, and just trying these little things like, oh my goodness, my teeth come together when I swallow. It's a necessary part to stabilize the mandible in order for my tongue to touch my palate and propulse the food back. It's absolutely like, okay, that makes total sense, but no one's talking about it.
I can't believe this. I feel like this is not even my area of clinical specialty. Anybody who listens to the show knows that I don't know anything about this, my mind is blown.
Yeah, so I don't think these kind of connections can come by staying within your field of expertise. They can't. The biggest thing for me was the fear of leaving my field of expertise and learning a different field at my stage of career. But the growth potential is huge. And then the ability to contribute is huge, um, by taking those steps. But you never know it when you're in the moment. But that's kind of the history of, again, why left my private. I had a multidisciplinary private practice, had it for decades. And then I left it to study this.
This is fascinating. So I'm thinking about all of the SLPs listening who hopefully I assume I was not the only person whose mind was blown and just had a really odd sensory moment trying to swallow without my teeth touching. But that leads me to believe that there are many other aspects of the oral phase of the swallow that we maybe undervalue just because of our lack of knowledge or our hyper focus on content knowledge that comes specifically from our silo.
Yeah,
What
absolutely.
are some of those other variables?
Yeah, like so when I studied your literature, right, I was looking at what are these phases of the swallow, and it's described by Logman as being like the oral phase, the pharyngeal phase, and the esophageal phase. Like it was a clear framework that is like in the classic literature. And it's really, the bolus is prepared in the oral cavity, transferred through to the pharynx, and delivered to the stomach through the esophagus. And it's a mechanical description. But now we're talking about the pre-oral phase, right? So we're expanding upon that. And the pre-oral phase is before the food even comes into the mouth. This is a phase which basically there's an impact on the swallow because your thoughts come into play, your intentions, those actually shape the swallow. So you get attention, you get anticipation, you get the reward system is activated, saliva is activated. And so it's like this whole sensory motor cascade even starts before the swallow begins. And that's like Schoen and Elsner talk about that in their articles. Um, so really, it's just recently that we're starting to do away with this mechanistic approach and just saying, well, the oral phase is this, and then the pharyngeal phase starts. Because the biggest issue, Kate, that I saw and what made me really delve into this was the conversations I've had with SLPs. It's really about this idea, well, we don't need to talk about changes in like my patient has pharyngeal phase deficits. They don't like the oral phase is not critical for this patient. And only when they have an oral phase deficit would they start talking about some of the things that we're going to get into later, which is like functional textures. And I'm like, no, 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 no. Like the oral phase impacts in a sensory motor fashion the pharyngeal phase. It is continuous, it is not siloed. And so it was really interesting. In fact, at the presentation I gave in Cleveland Clinic conference last week, it was just one of the SLPs raised her hand and said, how do I take the information of how do I change people's mindsets about the oral phase actually being a continuous, it's the oropharyngeal phase, right? And it's not like I'm creating this. This language was created and published upon by, Katrina Steele, for example. And they were starting to melt away those drawings of a mechanical structure and the boundaries of those mechanical structures, and just say, this doesn't exist neurally. This doesn't exist. It is one system. It's one sensory motor system. And I said, it's a paradigm shift. This is why it's so hard, is because we're shifting away. Someone's been taught. But by continuously talking about it, we're going to start to really expand our thinking of the oropharyngeal phase. And I'm hoping today that I can lend some of that information about that sensory motor traffic and how it's influencing the pharyngeal phase of the swallow.
I love the concept of paradigm shift. I think this is how fields evolve. This is how professionals evolve, right? Boundary spanning, reaching over the aisle, talking with other professionals, integrating knowledge from different fields, different researchers who have different values, have different incentives for publishing, et cetera, et cetera. I wonder, just kind of saying this back to you, we're moving, what the impetus here is moving away from siloed phases of swallowing, right? So looking at it as one continuous fluid sensory motor system that is much more complex than we give it credit for, or maybe what we're taught in graduate school. And I have to imagine there are a lot of SLPs listening who don't have access to a dentist, or maybe don't have a lot of collaboration time to learn from the other professionals within their medical network or within their hospital or wherever they are. I wonder if you could start to unpack some of these details for us. So, for example, I'm just looking in our notes here. You've mentioned chewing is a really big piece of this. You've also mentioned texture as a really big piece of this. What are some of the other more specific variables that we need to consider if we're looking at this as a more holistic system?
Yeah, I think that, what we should do is really talk about what is happening, like what are the patterns that are happening in this oral phase that influence the pharyngeal phase, and what is it that I'm really talking about? So, it is a little bit of a dive, if you will, into the neurology, but I'm not going to get into the weeds too much, because I think the exercise of that is to validate how important this is, how important the oral phase is to the pharyngeal phase of the swallow. Um, and by the way, Kate, if you went to your dentist and said, "Hey, let's talk about this," they are not going to know what you're
I
talking
believe you. I love my
about.
dentist, but I believe you.
So just beware, to any SLP out there that, yeah, it takes a lot of thinking outside the box. But anyway, so let's just talk. Okay, I don't want to scare anyone, or don't turn down your volume. We're going to talk little bit about the cranial nerves. So the importance here is cranial nerve 5 is a trigeminal nerve. And if you talk to your dentist about cranial nerve 5, they know what you're talking about because they numb it every single day. So, but the interesting part is, what is the sensory input that is coming in the oral phase? And so everyone knows cranial nerve 5, 7 is facial, right? And everyone knows 9, 10. And all of those nerves are sending this dense continuous input to the brainstem. So that's the interesting part, is it's sending this information to what's called the nucleus tractus solitarius, or NTS, which is like a hub of sensory input. It's like a highway. And so what happens is this sensory input from the mouth goes to the NTS, and that signal loops to the nucleus ambiguous and the swallow central pattern generator. And I think that talking about the central pattern generator in swallowing is I'm hearing it more and more often because that is essentially how we, neurally speaking, initiate that swallow. And so from there, the CPG produces that motor output, right? And what's interesting is cranial nerve 5 is chewing, right? Trigeminal nerve stimulates chewing. It's V3, right? It's V1, V2, V3. We're not going to talk about V1, but V2, V3. V2 is maxillary, V3 is mandibular. So just think about it. Like you are sending in chewing constant feedback to the swallow central pattern generator, right? So this is rhythmic jaw movement coming from this trigeminal nerve. So the key is chewing isn't triggering the swallow, it's priming it. It's bathing it with information essentially and puts it at a heightened state of excitability to lower the threshold to gain a really nice pharyngeal swallow. So it's really kind of interesting when you think about that and you're like, wow, just the act of chewing is changing the center for the swallow. And it's kind of priming it. It's getting it ready. It's warming it up. And so, you can think about all this happening in the brainstem, but guess what? Consider that like a continuous highway of information. It's just like, okay, you feel food in your mouth, you start that it's a sensory pattern. It goes to the brainstem. Your body says, okay, time to chew. So there's a motor input, right? The motor comes back and says, chew. Oh, chewed. Now what's the sensory information? Goes back, goes there. And so you're not swallowing every time you chew, but when it's giving the information of what's happening. And like we said, teeth come together, final moment, bolus gets transferred, right? So the interesting thing is information is going to the brain as well. So this is brainstem activity. That's where the central pattern generator is. And most people are surprised to know that we in dentistry have a trigeminal central pattern generator because we're kind of like doing this swallowing is a CPG, chewing is a CPG, and they connect, right? And so it's really interesting to see what's now happening in the brain. Because like I said, it's priming down below in the brainstem, but up above, you're sending all this sensory information and it's going to different levels of the brain through the thalamus. And so you're getting like cerebellar activity and coordination. It's going to like the primary motor cortex, like we talked about controlling jaw movement. But then you're going into the prefrontal cortex, which I think is the interesting part, which relates back to my patient Jan. So this chewing activity is going to our cognitive, emotional engagement, anticipation, attention, reward centers of our brain. So all of that said, the brain is getting the information too, and that is modulating the swallow. And so you have this engine and then you have modulation, right? So that is my way of saying what's happening in the mouth is affecting the swallow through two paths, right? And recognizing that is powerful for an SLP because you're basically understanding now the huge importance the oral phase plays from all of those cranial nerves, but I'm going to talk about cranial nerve 5 on the swallow. And we can talk about a little bit about what I've seen in SLP literature. It's like, oh, I can take an ice cube, right? That's thermosensory. Or we can use a sour stimuli or capsaicin. And I'm like, yes, those are awesome. Those are chemosensory, thermosensory inputs. What I'm talking about is mechanoreceptor inputs. Guess which one is stronger? Mechanoreceptor wins the day,
Interesting.
right? Yet we're using those triggers on a swab, ice chip, to do what? It's triggering the swallow reflex. You're going to get an instant trigger, right? That's what you're going to see. Is it continuous? No. What's continuous? Chewing, right?
Interesting.
So you're looking at stimuli patterns and effectively what's going to be the most long-standing stimulus pattern, right? What is going to be continuous? And it's chewing. So in fact, Steele did a study looking at this, and she compared these stimuli, and she saw that, the tactile pressure of that she looked at different thicknesses of liquid, but she compared that to the tongue palate interface, to basically start the propulsion of the bolus towards the pharynx. She basically said that is a much stronger impulse or stimuli than sour, sweet, bitter flavors, thermal, cold, room temperature. Those did not impact the pattern of the tongue to palate pressure as much. So it was an early kind of like aha moment to say sensory stimuli are not all the same, and they're impacting the swallow very differently. And what's most powerful is texture. Texture or tactile pressure wins the day.
I'm so fascinated by this. And I first want to say your crash course in neuroanatomy was wonderful. I didn't fall. I'm riveted by this. Nobody turned off their volume. Nobody muted anything. What I am so interested, and again, as a disclaimer, this is not my area of clinical expertise, but I am thinking about the number of times, either on this podcast or just years in the field, I have heard about things like modified diets, or I have heard about things like issues with dentition, or I have heard about, all liquid diets, right? And in so many of these instances, we're dealing with patients who are not chewing.
Right.
I'm just operating under the assumption that this is a relative it does sound like a paradigm shift, I guess is what I'm saying, only because if you're talking about sensory input that is that consistent and influential in this whole system, we need to apply that paradigm shift to our clinical decision making, I assume.
100%. Yeah, texture modifying is huge, right? And we can talk about that from a number of different perspectives, but we know that, like I said, that tactile input is a reliable trigger, right? It is the most reliable trigger for tongue palate pressure to initiate the swallow. And it's more consistent than taste and temperature. But Dodds, really early on, like maybe before some SLPs were born in 1990, said that they found that purees often failed to provide enough tactile load. So they were looking at molecular residue. It was a modified barium swallow study, and it was amazing because he was just looking at the big picture. What happens with puree? What happens with semi-solids, as they called it, and solid textures and liquid textures? And what they found was that there was a delayed onset. There just wasn't enough tactile load with puree, and they had more molecular residue. Well, to be honest, it comes to a question of safety. Would you give everyone then a solid texture just because of that study? No, there's other parts to the equation for sure. But, it just kind of boded for me to look a little bit further. Well, if we're getting under stimulation with puree and it's a slower onset and more molecular residue, then what is a safe consistency? What is safety?
What?
What does that mean?
Yeah, what does it mean?
I know.
I don't know.
So I think it's really, I hope that what I'm going to shed is that our talk about safety isn't really a talk about sensory load. And what I'm going to try to do is bring sensory into the equation, because how the body behaves is oftentimes what is it feeling, right?
Right.
And so when we look at IDSI, and I love IDSI, I think IDSI is a phenomenal framework, and it's hard. We could talk all day about IDSI and the challenges of adopting IDSI.
And for
But
our listeners who aren't familiar with ITSI, can you just share what does
oh,
the acronym stand for?
Oh, it's International Dysphagia Diet Standardization Initiative. And essentially, it was a way to standardize food textures and liquid textures according to rheology and particle size. So it was a way to provide something super user-friendly to test foods. And really, it was a framework around safety. And so what's interesting is this texture framework um, is requires some conversation around sensory because it's different. It's a different conversation. When you talk about particle size, right? Let's just focus on solids for now. If you're just talking about particle size, what we're talking about is choking risk, right?
Right.
That's really what we're talking about. It is not a framework for oral phase activities, right? It's not going into that depth of understanding or sensory stimulus. It's really about we're going to just measure these things according to bolus size. Like what is the size of the particle that is being swallowed, and can that person swallow that? But let's just kind of, Kate, for grins, just talk about level 4 puree. So IDSE puree level 4. If anyone is involved in IDSE, most people understand, the spoon tilt test, how it lumps on top of a spoon. Um, let's just say for grins that we've got applesauce in front of us, we've got a pudding in front of us, and mashed potatoes, and they're all level 4 puree. Okay.
Okay.
So they all pass. You're like, yay. But then when we think about the behavior in the mouth, they're going to behave differently. And the thing is back to that whole conversation about tongue palate pressure, just think of applesauce. It's really slick, right? That
Right.
water percentage is high. It has a different, it almost has a Newtonian-like behavior. It mixes with saliva, it clears easily. Now let's take that level 4 pudding, right? It's going to resist a little bit more. You have the tongue, it needs a little bit of tongue palate stripping, like it needs to have some pressure of the tongue. And you could probably see this on modified barium swallow if you had time to test applesauce, pudding, and mashed potatoes. You would see a different propulsion effect, like how much shear um, thinning is what it's called, or effort is required by the tongue to the palate. Then you take mashed potatoes and it's pasty, it's adhesive, right? Just think about it, but it's still gonna like fall off. But if your force isn't high enough, it's gonna leave a residue, right? So you need a little bit more force. So the takeaway is it's the ensures safety, not sensory equivalence. So it's a different signal to the brain. Each texture is giving a different signal. So then you're like, oh my gosh. So that means that my patient that's on a puree diet could be getting different input from their plate of food, which has mashed potatoes, applesauce, and maybe their dessert pudding, and their behavior has to alter dependent on these different foods that are all ITSE 4. And the answer is yes. It's
That's
different
insane.
sensory.
That
Yeah.
makes no sense.
Yeah.
Well, I mean, I just feel like in a classification system, if everybody's given the same classification, then one would be led to believe that they have the same impact. They have the same output. They have the same influence on whatever, if that's a level of input, then they have the same it has the same influence on the mechanism where there's going to be an output, right? Because it's graded the
100%.
same. It's like, graded or given a level. So if they're having different impacts, then they should be graded differently,
I
right?
know, but it's just think about how hard it was to bring ITSE about. Like
Right.
it is,
Systems
if
and
I'm
industries, right?
talking about a level of complexity that is really hard because, there's so many different influences on how that person take on that challenge. But what I think it raises the question, Kate, is when you're doing your modified barium swallow and you only have a limited amount of time and you can
Right.
only test, maybe you're testing pudding and then you're going to a cookie, right? There is a huge amount of extrapolation an SLP is doing to say what diet texture they're good for. And there's a huge leap of faith that the patient can actually manipulate those textures based on that input. So we are not getting the input, the cognitive input to our brain about the sensory input that our patient is going to experience by our diet recommendations. So yes, I think that, later, like we don't have time to talk about today, but just basically how we can start to create frameworks for not for this. How can we start to kind of create a knowledge base about texture that helps us make clinical decisions that are relevant to an SLP?
And I have to assume that the first barrier here is awareness.
Hmm.
So, understanding that these different level 4 foods, or understanding that tactile feedback is important, and that there are, other cognitive and social emotional impacts that are going to be happening in neurologically, and as our patients experience these phenomenons in their regular lives. I feel like just knowing that those things exist is a really, really important piece, instead of just being like, this is the prescriptive way that I was taught to treat this problem. We're going to use level 4, and then I'm going to send you home, or I'm going to send you over to this department, or whatever your sequence
Yeah.
of steps is, right? Just understanding that it's built a little differently, and that I'm going to use your words, that there is a paradigm shift is a first really important step.
Yeah, 100%, Kate. Like, just for example, like in a rehab hospital, a therapist might grab a pudding, but if she can go to the kitchen and get a mashed potato that's a puree level 4, she might have a different cue for the swallow than the pudding in her therapy, in her therapy session. So understanding that can help tease out and elongate the learning the patient has in order to rehabilitate their swallow, the effort that needs to be put into it before graduating them to say mince moist or soft and bite-sized, right? So I think that that's the direction that I'm going, is like how this is a conversation that is really about rehabilitative effects. And I just want to throw out a term here that I'm hoping will become more commonplace with SLPs. It's tribology. And it's really this interesting thing because IDSI is a safety lens, right? You do the flow test, particle size, spoon tilt test, fork pressure test. Like those are all safety lenses. And tribology is food physics. So tribology is really discussing when food enters the mouth, how it is how it basically react, how does the oral environment react to that food? Or how does the food react to the oral environment? And so it talks about friction, right? Slick versus pasty, like we talked about with, mashed potatoes versus applesauce. That's friction. And that has an impact, right? And lubrication, saliva interaction. Well, how much saliva do you need for applesauce versus mashed potatoes? Right? So the inherent moisture of food is an impact. And so adhesion is that clinging to the tongue palate. So like this is tribology. It's been around forever in food science. And yet it directly relates to the sensory motor input that influences the swallow.
I'm like irritated that I've never heard of this until just this minute, because what you're saying is so common sense. Even as a person who does not work in this field, I know that certain foods in my mouth are going to feel different, interact with my saliva differently. I was immediately thinking of those, dissolvable solids that we give kids, right? I mean,
Yeah.
there's just so many very specific and important qualities. And I'm asking myself the question, if any, if this has been around in food science, are there other disciplines that are using this information, and speech pathologists are just late to the party? Like for example, I know occupational therapy sometimes works with the with the oral phase of feeding. Are they using this terminology? How has this great information been kept from us for so
I,
long? Is
to
I
be
guess my
honest,
question.
I don't think so. I think it's again a situation of siloed advanced science in different disciplines that hasn't crossed over.
It's wild.
So I'm honestly excited about the prospect of bringing it to SLPs and discussing tribology and connecting those disciplines because historically, no. Um, and it's just, your question was about, the input of modified texture diet. So we know that it's a low sensory load with puree, and it doesn't fully stimulate those oral pharyngeal circuits. Um, and it can affect our, getting to that swallow threshold, like I said, priming the swallow and reduce and creating excitability. Well, you don't masticate when you're on puree.
Right.
So then are we priming the swallow central pattern generator with puree? No, we are not getting it to a higher level of excitability and warming it up. So you're losing that sensory load. And so, in my opinion, that can directly affect safety, right? And it just, I started to think about, so this summer, I did this kayak expedition, right? So it was 10 days on the open ocean and it was intense. And yeah, just 10 days.
Nobody can see my eyeballs just became the
Yeah,
size of
it
teacups.
was, it was, I did it on purpose. I wanted to do it. I was excited. It was like literally something I've wanted to do since my 20s. And the interesting thing is when you're on the ocean, right? You are getting your cues, sensory cues, the air, the wind, right? You're looking at the water, you're feeling the water. You're looking at the shore, your visual cues, like where am I? And it's helping you navigate. And then we had to go at 4 in the morning. There was a big gale force wind coming in, 30 knot winds. And if we didn't leave, we would be socked in and stuck in this inlet for days because it was a massive storm coming and, it was like creating these
Sure.
crazy circular patterns. So 4 o'clock in the morning, complete and utter fog. I couldn't see horizon. You can't see the difference between the watercolor and the sky. It's all one. So your sensory cue is gone, your visual. And we are so dependent on our visual cues. And so it made me think as I'm kayaking and I'm like hearing the waves crashing against the shore to identify where the shore is and how far I
I'm terrified for you right now. I'm so
am.
glad I know that this story ends with you safe on dry land.
It was kind of an interesting moment because you instantly have to change because you lost a sensory input. What happens? So as I'm kayaking, I'm thinking about people that are on puree diets. I was like,
That's how you know that you're really passionate about your work.
but I was just like, that sensory cue is gone. It's
Right.
gone.
Right.
And it's not just for a day, it's gone for days to months to the lifetime. And so how they adapt, um, when they lose that texture message, is something that, it affects their limbic system, their, how they, like we were talking about that, um, the familiarity, the attention, the engagement with food. I mean, it's that limbic system that's affected, but you're also talking about that tactile, the taste, the smell, the temperature. By the way, solid food has much more intensity in taste, right?
Right.
So you're losing that too, right? With a puree diet. So you can even see this with people that are tube fed, right? When with tube feeding, they're getting all their calories, they're getting all their protein, right? But they report hunger. So you'll oftentimes hear this. It's not universal, but you can hear this. And what is happening? Why are they hungry when they're getting all of the nutrition and they've lost their oral brain sensory loops, right? You're not getting that sensory stimulation.
Right.
And so even if there's possibility to have brief oral sensory input, you can restore satiety and engagement with that patient and dramatically change their quality of life when they're on peg tube.
And I
So,
have to assume I'm kind of drawing from a personal experience. I had a dear friend who was NPO for an extended period of time because of his cancer diagnosis. And he was very, very, very sick. And I remember hearing that he became a bit food obsessed. So he was, kind of like ordering ice cream to his kids on an impulsive basis from his hospital bed. He was like really obsessing over food. And it was kind of bothering his family because you could tell it was really bothering him. And yet the staff, he was very, very ill. And I think that it was very low in on the priority list of the staff who were working to, save his life, treat his cancer. And I'm just thinking about the context of the places where we work and the priorities that we're navigating when we're working with our patients, and how the SLP could maybe help advocate for this component of the lived experience of being sick or being NPO or being on a modified diet, and how that resonates with our neurology and our emotional experiences of living with these kinds of disorders. Does that make sense?
100%. I almost think of it as oral phase hunger. Like
Right.
you are, it's a different hunger. And what you're describing is absolutely true, advocating for the importance of that and what's actually happening. Because in palliative care, or, I have talked with SLPs who support patients with ALS, right? And it's the same thing. It's like, what are we doing here? Everything, it's not that it doesn't matter anymore. And almost I could say that quality of life at end of life is critical. And what he's probably doing is thinking and ruminating about texture. That's
Mm-hmm.
probably what he's doing. And so buying that food is a way to extend the gratification to someone he loves because he can't have that gratification. But his
Sure.
brain is almost remembering texture, and he's trying to satisfy or satiate that cue, right?
Mm-hmm.
Very powerful. Um, and that's the kind of thing where this whole idea of functional textures, how can we give a texture to someone that, is on a modified texture diet that supports that early tactile stimulation but maintains safety? And that's kind of my area of study, right? Like this is how I'm trying to bring together this, dysphagia science and food science and prosthodontics. Um, so I'm trying to, in a way, reignite those chewing pathways and those neural pathways and still stay within the realm of their texture modified diet, assuming that they can have PO intake.
I'm kind of thinking about, we have about 10-15 minutes left here, and I'm thinking about just clinical takeaways. I mean, we've already discussed how awareness is the most important piece, right? So those of us who are listening, if this is completely new information, first of all, being aware of it, thinking about that paradigm shift, thinking about the cognitive things that our patients are experiencing, their lived experience, advocacy, talking with other professionals, like the woman who asked you that questions at the conference last week. How do you, talking to other professionals, really helping to create this paradigm shift, but also the action steps that we can take in with our patients who might be experiencing these things now. I wonder if do you have any basic suggestions for how to take this paradigm shift into action?
Yeah, I think so. We are doing early studies looking at this. So we've published 5 clinical studies. And, I really would like to talk to you about solutions. So I'm talking about the problem, right? But I do think that functional texture is a solution. And, really what I what I would like to do is provide a new tool for SLPs in their toolkit. But it's interesting because it's food as therapy. Like it is food, but I think food can be a tool. And I don't think that's ever, I don't think it's regarded that way, right? Like it is just a different way of thinking about something that sounds mainstream, but it's not. It's so let's just talk about functional textures. These are foods, functional textures, like they're food structures engineered to give that early tactile stimulation, tongue palate propulsion, and giving more of that trigeminal feedback, right? Like that chewing feedback to increase that excitability. So can we do that with a texture? And the answer is yes. So it's not the chemosensory, it's not the thermal, which are transient. Like I said, those are like transient cortical triggers. I'm talking about tactile input. Can we essentially modify food so that we can give the tactile input that someone needs to provide that repeated stimulation to the brainstem?
Interesting.
And can we introduce it at the puree stage? Can we introduce it early on when they're on a solid diet, which is the puree solids, to re-engage those chewing patterns and basically jumpstart the system through this a new texture, right? And so I think that we know that if we already know that by eliciting early mastication, we are affecting the limbic system, like we said, like we were talking about that motivation, reward, emotional regulation. So we know functional textures can stimulate a person. Think of it this way. Think if you do that, how much more engagement are you going to get a patient in therapy? Like if you're stimulating the limbic system, are you building hope? Are you
Right.
building engagement? Do they buy into the therapy more? Absolutely. They're more in it. And so that's a really important property. But functional textures are, we want it to activate, we want it to stimulate those sensory pathways. And, can we elicit a bite force, lip tongue coordination, pre-oral anticipation, right? Mechanoreceptor stimulation. And of course, can we meet the rehabilitative goals? And that, my friends, is really a conversation about transitional foods, right? So functional textures are found in transitional foods. And the reason I use that term is because that's an ITSE term. And most people are aware of it because it's on the side of the inverted pyramid, but they don't really know what it does, right?
Interesting.
And my point is that transitional foods is measured according to safety. And I'm saying, it's a huge category. It requires a lot more knowledge. Just doing the fork pressure test is not going to tell you how it's going to behave in the mouth, like we said with the puree. Exactly the same thing with transitional foods. But in order to be a functional texture, you want it to stimulate the patient early on and still be safe, right? You want it to predictably form into a nice cohesive bolus so you can challenge that patient appropriately and maybe focus only on tongue palate pressure, focus on early chewing behavior, focus on containment, but you're not actually creating more risk for that patient. And the value in that is tremendous because, like I was saying, it's going to affect the pharyngeal swallow. It's going to affect the timing, which is efficiency, right? And that's what we studied. We've actually studied this in fact, it was just published in Laryngoscope last month. And it was looking at different textures of food on fees and what the behavior is. And we used transitional foods, high dissolving transitionals that dissolve to level 4 puree, and we compared it to applesauce. Well, guess what? Applesauce is slick. It falls everywhere in the mouth, right? Containment is actually hard when things just slip away, right? And so we have this puree that leaves more residue, not only in the oropharynx, but in the hypopharynx and like in the esophageal spaces as well. So it was just quite remarkable to look at that in comparison to a transitional food. So it's really taking into account, well, what's happening? Is it forming into a nicer bolus? Is it providing more tactile cue in the tongue palate pressure than applesauce? And the likelihood is yes, it is. So
Interesting.
we have a functional texture here that patients can actually manage better, is reducing residue and improving timing of the swallow. And people don't know about it, right?
Interesting.
Yeah. So I think overall the take home is that this is a texture category that most people who are transitioning to ITSE don't really look at transitional textures, and they really should for that sensory motor input and how it can help in rehabilitation of the swallow through everything that I talked about today. And that transitional foods are highly differentiated. There's high dissolving, low dissolving. Some will require a chew, a modest chew. Some require no chew at all. Some dissolve to a puree. Well, very few dissolve to a puree, but most are like different textures that they dissolve to. Some will particulate like crazy, and someone has to like find the food in their mouth. That's a
Mm.
much harder texture. So understanding that you want to start early, go for a transitional food that dissolves to puree and use it in a way to support a better swallow for your patient.
I, as I've already disclosed, know very little about this clinically, but I'm now fascinated because I think that there are so many components of this problem that are being heavily influenced by the status quo of how we've always done things, by lack of new information, lack of collaboration, siloed industries, right? And I think I just love sharing information that is pushing the envelope in terms of helping us do better by looking. I always think of it as like a cartoon. You're looking over the fence into the neighbor's yard, like, what are you guys doing over there? Right. And here we've got this wonderful blend of dentistry and food science, food industry science. And it's opened my eyes to so many ways in which we need to change the status quo. We need to continue to push this envelope, have this conversation, share with our colleagues the power in that paradigm shift and thinking of things a little bit differently. In our last few minutes, you've mentioned so many resources throughout this episode, and obviously this is just scratching the surface. I hope you will come back and continue this conversation with us at some point. In our last few minutes, are there any really great, reliable, evidence based resources, aside from all of the articles that you mentioned, which I will list in the show notes? So if anyone's listening and they've been folding laundry or running or whatever, all of the reference list will be there. Are there any other websites or things that we should consider in terms of furthering our own learning in this area?
Well, I pride myself on my website having like basically I feed it information so that I can further develop this area. Um, so if people went to savories.com, they would see in the blog section and the professional section the research. In fact, I have full references, PDFs, so that people can look into this information. Um, and, you know, uh, it's hard. Like ITSE does have some information, but when it comes to transitional foods, it's really about it's very current, right? Like we're talking about recent research in this area. And typically, Kate, transitional foods or meltables, that was in pediatrics, right? So like what we're talking about here, I mean, I didn't state, it's basically it crosses all ages, but historically the viewpoint was very not talking about sensory motor patterns with food. So I just think that this is it's much easier for people to look at resources on the website and try to learn from there. ASHA, National Foundation of Swallowing Disorders, has some material there as well. I've done a recent presentation webinar for them called Good for Chew, and that's really great.
That's a really cute title.
Elizabeth is hilarious, but she was trying to play on different pop songs. And so that was one of them. I've done work with Dr. Samantha Schoon, and we have webinars there as well on the caregiver burden and how food relates to that. So I think that would be a good start. And certainly, Kate, people can contact me and ask for more information.
Thank you so much for sharing all of your wisdom with us today. This has been a truly unexpectedly eye-opening experience. Not doing this for a living, I have just enjoyed this conversation so much, and I'm sure our listeners have as well. I want to take a quick minute to thank our incredible team who helps to make this podcast possible. Dr. Anna Palamumi, and who is our ASHA CE administrator, Tegan Ahern, our production manager, who wears a million hats and keeps the project alive. Darren Lopez, our production assistant, who does all of our post-production and course materials. Tracy Callahan, who's our advisory board liaison, and along with Dr. Mary Beth Schmidt, who helps provide consultation to our peer review process. And last but not least, Dr. Reva Bearwall. Thank you so much for being here with us today. We really appreciate all of your time.
Well, thank you, Kate, to you and your team. This was really fun, and I enjoyed our chat.
Thank you so much for joining us in today's episode. As always, you can use this episode for ASHA CEUs. You can also potentially use this episode for other credits depending on the regulations of your governing body. To determine if this episode will count towards professional development in your area of study, please check in with your governing bodies, or you can go to our website, www.slpnerdcast.com. All of the references and information listed throughout the course of the episode will be listed in the show notes. And as always, if you have any questions, please email us at info@slpnerdcast.com. Thank you so much for joining us, and we hope to welcome you back here again soon.